All right, I think we're going to go ahead and get started here. Thank you everyone for joining us today. My name is Dr. Amy Bender. I'm the Director of Clinical Sleep Science here at Cerebra, and I'll be your moderator for today. One of our main goals of the round is to just try and get you thinking beyond RNK, beyond AHI. And so how do we actually help people sleep better with sleep disorders? So that's kind of the goal for today, is to kind of think beyond some of those standard metrics. Today, we're going to focus on odds ratio product, which is an EEG metric of sleep depth. And Magdy's going to go into detail on that, on a new way of looking at sleep architecture using ORP. All right, I'm going to introduce our speakers. So Dr. Charles Samuels, he's going to be our host for today. He's the medical director of the Center for Sleep and Human Performance, a clinical assistant professor at the University of Calgary Faculty of Medicine, as well as kinesiology, and former president of the Canadian Sleep Society. He's been PI on numerous clinical trials, has many publications, and a pioneer in areas of shift work and health outcomes, and as well as assessing sleep in elite athletes. His clinical practice and research focus on the effect of sleep deprivation and and disruption on health and performance, and is keenly interested in individualized clinical treatment strategies. Our Dr. Younes is going to be presenting on the case and the sleep architecture methods using ORP. He is a distinguished professor emeritus at the University of Manitoba. His research is in respirology, critical care medicine, and sleep medicine, which has resulted in approximately 200 original peer-reviewed papers and book chapters and reviews, along with numerous patents. He truly is an innovator in developing novel sleep metrics that will help better diagnose and treat sleep disorders. And I just want to say that Dr. Samuels and Dr. Younes have many commonalities, but there is one in which they were both having to deal working with me. So Chuck was my former postdoc supervisor, and I'm currently working a lot with Magdy as well. So just to give you a little bit of history there.
Great. Yeah, so I just want to give everyone on the rounds a little bit of background. Magdy and I have been nattering about these things with the ORP for many years, and in the last year or 18 months, we've been sharing cases with Magdy. He's been analyzing the data, and then we've been doing rounds just within the center, and we came up with the idea of offering the rounds to, nationally, to other groups and sleep specialists, in the interest of introducing everyone to the concept of the odds ratio product, which we clinically here in the center find very interesting and helpful actually in evaluating complex cases, mostly around the idea of comissa, so comorbid insomnia and OSA, and seeing if the ORP helps us discriminate patients in terms of the effect of their insomnia on the OSA or the reverse. And so it's just been something of interest that we've now wanted to go out to the wider group of sleep specialists, researchers, and clinicians out into the community and go over cases. So we bring a case to our rounds here on a weekly basis and then find a few that would be of interest to Magdy, and we fire them off to Magdy, and then he looks at them. So what you're going to see today is the second case of a number that we've sent to Magdy. And I'm just going to review the follow-up of the last case that we went over for those of you that were on the round. So if you could bring the summary slide up, Amy, that would be great. So this was a 50-year-old woman who came to see us with a history of frequent nocturnal awakenings, maintenance insomnia, snorting and snoring, as well as non-restorative sleep and fatigue. She was menopausal with hypothyroidism and eczema. Medications were desiccated thyroid. She was on DHEA, sertrazine, famotidine, and ketotifen. So this combination of medications, they're antihistamines, which most of you would know, come from a very specific physician here in Calgary. And he refers many, many patients to us. And he does functional medicine. And so he has people on lots of antihistamine. That's why you're seeing this, because it's rather odd. But in any case, we do the sleep evaluation for him. And this patient saw Dr. Askin here. And so she went to the lab on the assumption that she would have sleep apnea based on her presentation. She had 400 minutes of sleep. She had a sleep efficiency of close to 80% with a WASO of 100 minutes. Her RDI, not AHI, her RDI was 33 events per hour, mostly RURAs. She had a mean SAT of 93 and her DSATs were down to 88. So this is one of those borderline cases we see where, we're not quite sure whether it's the state of sleep causing the closure of the airway or whether it's legitimate OSA, maybe high upper airway resistance, causing sleep disordered breathing that is the underlying cause of her problem. The ORP in non-REM sleep was 0.88, which I'll leave the numbers and understanding the nature of these numbers to Magdy to discuss. In REM, the ORP was 1.93, which has implications, those differences. And then the ORP9, again, an assessment of arousal is 1.37. She failed to tolerate AutoPAP, so she was treated as if she had significant sleep disordered breathing. She failed APAP, which tells us one thing: she simply could not tolerate it. She was enrolled in the behavioral sleep medicine program here at the center with one of the clinicians. She had 5 visits. And over the course of her 5 visits, which it would have been over a period of about 3 to 4 months, I'm pretty sure, her ISI remained within a window of about 2 points. So not a clinically significant change from 9 to 7, but an improvement. More importantly, the clinician who saw her, Dr. Rasmussen, notes clearly indicate that she was doing better from her perspective, from a clinical perspective. She did not trial trazodone and has not been followed up yet by Dr. Askin. So that's where we stand there. I'll just turn it over to Magdy now to start the second case.
Okay, the case of today is 57. This is a patient of Dr. Samuels, a 57-year-old male with lifelong history of insomnia and sedative dependence as an adult. The diagnosis was made of severe sleep apnea in 2012 and currently treated with CPAP 20 centimeters. Excellent response to CPAP, but continues to experience maintenance insomnia on zopiclone 7.5 milligrams. The patient is on polypharmacy, as many of these patients are, antidepressants, stuff for blood pressure, and on zopiclone and beta blockers. He's quite heavy, but he's not terribly sleepy, has hypertension and had 3-vessel bypass, and has mild congestive heart failure. So he had a he had a sleep study, and I just summarized the important numbers here using conventional scoring. In the diagnostic study, his sleep efficiency was 54. He slept for only about 4 hours. Sleep latency was very short, had a lot of awake time after sleep onset. As we see, a lot of awake time, a lot of N1. I've never seen N1 more than like 3.5 hours, and very little, but we'll come to that later. Very little N2, no N3, no REM. So, and his total non-REM time is also about 4 hours. Now, the total awakenings, 152 in 4 hours of sleep. It's stunning. Arousal awakening index 98, and his AHI was 100. So clearly, and this is his histogram, and as you can see, it looks awful with all these arousals and awakenings, and hardly any stage 2, and the saturations you can see on top. So he was obviously put on CPAP, as you might expect, and these are the results on CPAP. Now, here is his histogram. He was on CPAP for several months, I think, before this study was done. I'm not sure, but I think that's the case. And we can see that his saturation now became flat. He has a lot of stage 2, and he got a little bit of REM. We can see here that his REM went from nothing to 29 minutes. So it's not what you might call REM rebound, but at least he got some REM. And the curious thing is that he did not get any stage 3 sleep. What happened with CPAP basically is a reversal of N1 and N2. So instead of most of non-REM being N1 in the diagnostic study, most of it now is N2, and you can see that in the histogram. But I want to point out something quite important here. Is that even though the histogram looks amazing, and this is just what the doctor ordered and what we all want to see, that there is a lot of misleading stuff here. What we expect the CPAP to do is eliminate the obstructive events, which it obviously did, and eliminated most of the arousals. The arousals went down from 98 per hour to 29 per hour. But it is misleading because the excessive amount of stage 1 and the limited amount of stage 2 is simply an artifact, an ASM artifact, because they tell us after every arousal, you've got to change the stage to N1 and wait for a spindle. So it's not really failure to go to stage 2. It's just the rules are such that you increase the number of N1 epochs when you have a lot of arousals. And what happened when the arousals went down is N1 went down and became N2 because you don't have to have a spindle every epoch. Once you score stage 2, you stay in stage 2 until it switches to something else. But when you have an arousal, you have to wait for a spindle to call it stage 2 again. So this is really an artifact. The histograms look amazingly better, but it is basically an artifact. So the issue then is, okay, with CPAP, we've accomplished what we wanted with improving the awakenings and remarkably improving the awakenings and sleep disruption and the AHI. But what happened to sleep is what we need to discuss. The red rectangles indicate that the change was either not important or even worse. So we can see that sleep time didn't really change very much. Sleep efficiency is still terrible. Sleep latency, if anything, went longer. Wake after sleep onset is lower, but it's still very high. The switch in N1 from N1 to N2 is, as I told you, because of the removal of the arousal. So you can argue whether this is an improvement in sleep. And there was no change in N3, a little bit of an increase in REM, and the total non-REM time didn't change. So the issue is, what did CPAP do to his sleep? We can't really tell from the conventional indices. All we can say is that the arousals went down a lot, but we really have no idea what is the impact of arousals on overall sleep quality. It's just an index of arousals, but you can have lots of arousals with good sleep and poor sleep without arousals. Okay, so now we move into my attempt at switching from conventional sleep architecture to an ORP-based sleep architecture. This is the conventional sleep architecture. It's expressed as % of total recording time. This is, as you may realize, this is a perfectly normal sleep architecture. A little bit of awake time, little bit of N1, mostly N2, quite a bit of N3 and REM. So this is how sleep architecture would be expressed by conventional criteria, and this is what I'm trying to do, is to make it based on, or at least we can have it not necessarily replace the conventional, but at least in addition to the conventional, so it gives us more information. The ORP is a continuous index of sleep depth that ranges from 0 to 2.5. 2.5, well, maybe I will show you some these are 6 30-second epochs. They're all scored stage 2, except the last one scored stage 3. And you can see that in the top one, it's sort of hard to score it as non-REM or awake. There may be a spindle here or there, but it's almost looks like awake. And then it keeps progressing. You get a bit more theta, more theta, more theta, and a little bit of delta now, more delta, more delta. So you can see that this is progression from very, very light stage 2 to stage 3. But when we use stage 2 and 3, we don't really appreciate these differences, and the patient can change from very light N2 to very deep N2, and we wouldn't even notice it. But notice what the ORP does here on the right side, that you can see that at the very top one, which is almost close to awake, it's very high near the top of 2.5, and down here it's very low, 0.6, stage 3, 0.16. So we can distinguish between these different levels of arousability within stage 2. And if we look at awake epochs, these are 4 epochs, all of them scored awake according to the ASM criteria, but you can clearly tell the difference between this full wakefulness and then I get starting to get a little bit of theta, a little bit more theta, and here we have an epoch that's split between 12 seconds of sleep and the rest of the epoch awake, but we still call it awake because of the rule that it has to be 15 seconds of sleep. So again, we see the gradations of stage awake, which we don't appreciate from the conventional indices. And actually, it turns out that these different stages are very important, as we're going to see. So now we go from 0 to 2.5. The last 3 are usually what is scored as awake by most polysomnographer. But this is drowsy awake. This would be something like here with microsleep. This is medium awake, and this is really full awake, like this one. So the sum of these 3 would be approximately what technologists would call stage N1. And you can see that this is a perfectly normal summary of thousands of people. This is a perfectly normal distribution that the 3 types of wake are equally present. And then we go into the sleep range, which is the first 7. We see there is a bit usually of very deep sleep. And then the highest values are in the second and third deciles. So this is deep sleep, and this is average sleep. The 4th one is light sleep. And the 5, 6, and 7 are really transitional sleep that you have features of both awake and sleep. And these are the ORP values that give techs the hardest time distinguishing awake from sleep, but they usually score it as sleep. Okay, now let me introduce you to what is normal using this ORP architecture. These are plots made from this one is made from 200 very young people. This is the effect of demographics. So this is very young people, 20 to 40, all of them are healthy. And you can see the normal distribution, some very deep sleep, mostly the second and third decile, and then it goes down to very little in the other ones. This is now from the Sleep Heart Health Study. We have 758, age 40 to 55, no OSA, no PLMs, no insomnia, nothing. And you can see that now the amount of epochs in deep sleep is less. The amount of epochs in full wakefulness is up a little. We go to 55 to 70, and the same thing again. This is going a little bit higher, and we've known for a long time that older people ask me, have a very, that they don't have much sleep pressure. So you can see in the oldest group, this is lowest and this is highest. So this is what I would like to point your attention to, is that normally there is this reciprocal relation between the number of epochs in the deepest sleep and with full wakefulness. When sleep pressure is high, there is a lot of epochs in deep sleep and very little in full wakefulness. As we have less sleep pressure, the the amount in deep sleep goes down and the amount in full wakefulness goes up. So that is the effect of age. The effect of gender, 941 females and 15 males and 1,500 females. Again, we see these females have less sleep pressure. And so you can see they have less very deep sleep and more full wakefulness. Now, this is BMI had nothing to do with sleep. Now, this is a very interesting slide and really tells the whole story. This is the same group, normal young people in Philadelphia, that were subjected to 36 hours of sleep deprivation. So this was before sleep deprivation, the baseline, and it is identical to the top one, except the scale is a bit different. But after 36 hours of sleep deprivation, so this shows you the pure effect of sleep loss or high sleep pressure on this kind of architecture. You see that the deepest sleep went up from about 10 to about 20. The next one went up from 24 to 34, and there is now very little, very few, no epochs almost in the highest full wakefulness. So that shows you that there is normally this reciprocal relation between the first decile and the highest decile, and the effect of sleep pressure. The more sleep pressure, the more we have in the first decile and the less we have in the last decile, and vice versa. Now, I just want to show you as a shocker, these are two people picked up from a data set. I don't know which one, but I picked them up because they both had normal, conventional. I just at random picked up two. As you can see, very little awake, 90% sleep efficiency, little N1, quite a bit of N3 and REM in both of them. So these are both having very normal, conventional histogram. And then we did the ORP architecture, and look at the difference. This one can never happen in normal people, because on the left side here, there is very little deep sleep, which would suggest either very little sleep pressure, or there is something else. There is no other explanation for very little deep sleep, except either very low sleep pressure, like, you slept very well before, or that something is preventing the patient from going down into deep sleep, like OSA or PLMs and so on. But if sleep pressure was low to explain this, then the number of epochs in the highest decile should be high. So finding that both of them are low is very unusual and indicates that there is something preventing the patient from going into deep sleep, and it is causing him to have a high sleep pressure, as evidenced by the very low full wakefulness. And notice this, the relation between the three highest decile is a decrescendo. In other words, the full wakefulness is the least of the three. This patient, which also had normal sleep architecture, look at that. She looks like sleep deprived, or he looks like sleep deprived, and very little down here. And so this patient really has to be investigated for something that fragments sleep. This patient has to be investigated for something, either primary hypersomnolence or narcolepsy or something like that. So that just was a shocker to me to see this in two randomly selected people with normal histograms. Okay, now let's see the OSA. So the left one, panel A, is the normal again. These are the sleep heart health study again, 2455 subjects with no apparent sleep disorder. And you can see again the normal pattern with some deep sleep here and modest amount of full wakefulness. Now, mild OSA, AHI is 9. We had 1,557 subjects in the sleep heart health study with between 5 and 15, AHI with an average of 9, arousal awakening index 27. And the shocking thing here, the amazing thing is there's hardly any difference between the normal and the mild OSA, you can find some statistical difference here a little bit, just a little bit lower. These are just a little bit higher, but I mean, basically the effect is minimal. Then we go to moderate OSA, AHI 19, arousal awakening index is 30. And again, the effect, we have more significant differences now. You know, these 4 went up significantly, these 2 went down significantly. But again, the basic pattern is very similar to normal, which to me told me that really we are over-exaggerating the effect of OSA. Most of these people with moderate OSA would be treated with CPAP, but their sleep is okay. And then we get into the severe OSA with an AHI of 42 and the arousal index of 38. Now we have much more impressive changes. We can see that these first 3, now the peak actually has switched from being the 2nd decile to the 3rd decile. It's being a bit rounded. And there are very significant differences, more increases in the high ORP and decreases in the low ORP, but it takes severe OSA to actually cause an important change in sleep quality. So now I did a study here, and we are about to submit it on 279 patients with very severe OSA, that all had split studies because they had very severe OSA. Their AHI was 68. Arousal awakening index was 50. And this is the pattern for the whole group. And what is amazing here again, these are all severe patients that were treated with CPAP. You can see that the first decile is very low, again indicating either low sleep pressure or fragmentation, preventing them from getting into deep sleep. But the ORP full wakefulness is very high. That's for the whole group of very severe. So that looks more like low sleep pressure or insomnia type. And these are the most severe patients that you can imagine. I'm just putting the normal here again, just for comparison. You see this boot-like pattern as opposed to this hump-like pattern. So now we go into utilizing the observation that there should be a paradoxical relation between the first decile and last decile. I split the whole group into 4. So took the lowest here, which has 2 possible reasons, low sleep pressure or sleep fragmentation, and got type number 1, has no deep sleep at all and very, very little full wakefulness. So this is a very abnormal pattern, and I called it the pyramid because it looks like the Egyptian pyramids. The next one also still has no, remember, of this 279, 61% had no epochs at all in the first decile. Whereas for normal people, only 6% do not have any epochs in the first decile. So this one is a bit like type 1, except pushed to the right. So the peak now is in the 6th decile instead of being in the 5th decile and instead of being in the 2nd decile. But it's not perfectly symmetrical like this one. So I called it the tilted pyramid. We have to change these names, but it's just okay for now. Type 3 still has no epochs in the first decile, but a lot of epochs in the, this is now the insomniac. This is clearly a very low sleep pressure pattern. And finally, there is the type 4, which are people who had some epochs in deep sleep and lumped them all together. And this again looks very much like normal sleep. So pyramid, tilted pyramid, the insomniac, and the saddle is like normal. So now we are going to see how each one of these responds to and here's our patient. Now we get to the patient. So could you write down on a piece of paper which type you think this patient is? And then we can take a vote on it later. So which type you think? It's definitely not type 1 because it has a lot of where do you go? Has a lot of full wakefulness. It's not the insomniac. It's not the saddle, so it has to be type 2, right? It's type 2 is like this, except it's pushed further to the right. So it's just a more severe form of type 2. Now we want to go see how each one of these types responds to CPAP. So this is type 1, the pyramid, and this is on CPAP. And you can see that there is a shift. You can clearly see a shift to the left, with the peak now moving from the middle here to the early. It's still not normal. It's still not normal, but it's much closer to normal than before. And we can look at the values here. This is the diagnostic study, CPAP study, ORP in non-REM, average 1.15. This is quite high because most of the epochs are in this transitional state, which has a very high ORP. Sleep efficiency was 84. Now on CPAP, ORP non-REM went down from 1.15 to 0.76, which is a very, very good response. But sleep efficiency increased only a little. Of course, it was normal in both cases. So this is type 1. Type 2, this is the tilted pyramid. You see again, there is a shift to the left. Now we have more sleep as a result of CPAP. And now we are beginning to see the final decile going up, but it's looking like the saddle, actually. It's basically CPAP normalized sleep here. We can look at the numbers. ORP non-REM 1.28, very high, went down to 0.89. Sleep efficiency hardly changed. So that's 2 in a row now that sleep efficiency hasn't changed. This is type 3, the insomniac. Again, all of them have severe sleep apnea. What you can see is these went up a little bit. That's all that removing the OSA did, just increasing the amount in these here, decreasing in the bad levels. But you see the sleep efficiency went from 56 to 63, which is also not very good. But that is what happened. And this pattern on CPAP in these people is exactly the same as you would get we got in the sleep heart health study from insomniacs with short sleep duration. So basically the CPAP here fixed the OSA, which had just a small effect on sleep quality and didn't do anything to the wake level. This is type 4, which I said they started out with a fairly normal architecture, and really nothing happened to them on CPAP. The actually ORP non-REM went from 0.84 to 0.81. In other words, it's worse. And sleep efficiency went from 75 to 70. So these people actually, their sleep gets worse, if anything, on CPAP. Let's look at our patient and what he did. This is what I showed you before. And we agreed, I think, that this is a type 2 who should respond like this. And here is what he did on CPAP. We can see now a lot more sleep on the left here. He had virtually nothing in the first 4 deciles, whereas now he has quite a bit, but not normal still. And look at that now, his full wakefulness increased from being here, to being here. But what is most interesting, and this is something we've reported on, is that the average ORP during wakefulness, you see this crescendo here, which means in awake epochs, the highest prevalence is epochs that are drowsy awake. They're not really full awake. So it's the frequency of epochs, it goes down as ORP goes up. Very little full wakefulness relative to the drowsy wakefulness. Whereas after CPAP, with the opposite, what does the opposite mean? It means now he has no sleep pressure, very low sleep pressure. He's actually got 20% of all his epochs in full wakefulness. So that means he has really no sleep pressure anymore, despite the fact that the improvement in sleep was not really back to normal. Okay, so this now is the final slide. I'm taking you to the first slide to explain and answer the questions that Sonny sent me. So this is what we got from the conventional sleep scoring, and I hope you remember that. And this is what the patient did using the ORP sleep architecture. Again, notice the increase in full wakefulness and the increase in sleep, better than before, but not completely better. So let us now see, here are the questions that I got, and that relate to how do we manage this patient. And I told you that with conventional scoring, we're not really sure what happened to sleep. Here we found that his ORP non-REM went down from 1.59, which is really high. You see, this is sort of the average of these deciles, very, very high. And it went down to 1. It's not that great, but it's a hell of a lot better than 1.59. But sleep efficiency is still very low. I showed you that before. Sleep. So the bottom line from all this is that CPAP, regardless of what type you are, does not fix sleep efficiency. It does not reduce awake time, but it can change the pattern during wake epochs from crescendo, from decrescendo to crescendo. So now one of the things we reported when they sent us this file, or I think Sonny and Chuck, they have the scoring. So it generated something called ORP9, which I don't know if you have heard it before, but the ORP9 is the ORP that happens with that we can measure within 9 seconds of the end of an arousal. It is really a marker of how fast sleep deepens after an arousal. And there's a lot of fuss about this as an index of how susceptible a person is to developing sleep disorders, because the slower ORP goes down after an arousal, the more likely you are to wake up again, because most of the OSA happens soon after an arousal. So if your sleep is still very light, then you are likely to wake up and keep getting one after the other. Whereas if the ORP drops down very quickly to deep sleep and you get some upper airway obstruction, it may not wake you up, and your own reflex mechanisms can wake you up. So the report that they got from our scoring is that ORP9 was 1.82, which is almost awake, which is really one of the highest you can ever see, and that it dropped on CPAP to 1.26, which is still high, but much lower than this. And in our first report of ORP9, we said that if you put patients on CPAP in a split night study, the ORP9 doesn't change, even though all the arousal awakening index goes down a lot. So we thought, or I thought, that ORP9 is a trait, but it turns out that when the apnea hypopnea index and the arousal index is more than 50, ORP9 is not accurate, because you're really not getting, when you have 60 or more arousals per minute, per hour, it's like one every epoch almost, and you don't really have time to go to proper sleep. So we're not really dealing with an arousal. We are dealing with a state of wakefulness that's just fluctuating. So I no longer put any emphasis on ORP9 if the AHI is more than 60. And his real ORP9 is 1.26, which is high, and with this pattern is completely consistent with a hyperarousal state. You see, he had no deep sleep, and sleep during non-REM sleep was an average of 1, which is again not very good. and of course he has a lot of awake time. So his ORP is 1.26, and the first question was, how do you reconcile 1.9 with 1.3? But I reconciled it now by telling you just ignore the 1.9, because the AHI is 100. So that you can't, that's like one every apple. So the next question is, does ORP9 help justify the use of a sedative? Well, that's related to the third one. In other words, if the answer to number 2 is yes, it does. The issue is, should you use trazodone? And before I say whether you should use sedative or not, I know I have to bring up an issue. This is the last picture I show you. An issue that's been bothering me for some time about the hyperarousal state, which this patient has. I'm just wondering how many people with so-called hyperarousal state are basically people who don't need much sleep. In other words, their lymphatic system in the brain is so efficient that it can wash out all the stuff that happened during the day in 5 hours or 6 hours, so that the brain is completely cleaned up and restored. So you don't need to sleep anymore. I mean, I know the ASM recommends 7 to 8 hours, but that is for the majority of people. It doesn't consider that there's a bell-shaped distribution, and some people need only 5 or 6 hours. So the problem here is, how do you distinguish, how do you identify this problem? And I show this picture. This is the time course of ORP across the whole night on CPAP. Okay, fairly good sleep, but a lot of awake time, as you can see in all these places. But the key thing here, why I'm showing you this slide, is how ORP starts out fairly low, not very deep, but fairly low, and progressively rises during the night. And towards the end of the night, sleep is very light and very fragmented. This is what you expect when you have restorative sleep. So what I'm saying is, this patient is happy with 4 or 5 hours of sleep. And the first line of treatment I would recommend is sleep restriction. And we keep gradually restricting sleep from 7 to 6 until the patient starts getting sleepy. Repeat the sleep study, and I can assure you that he will have better sleep and less awake time, and he may not need any sleeping pills at all. And you may start actually working on all these medications like venlafaxine and Wellbutrin, cause insomnia, and zopiclone depresses. So, so I would start with putting him first on sleep restriction to 7 to 6 to 5, and stop when he starts feeling sleepy, and he may feel just fine at that point. If not, then you have to consider a sleeping pill, and trazodone is okay to start with, but it may not work, and you may have to try another one. I'll stop here. Thank you very much.
Thank you, Magdy. That was fascinating. We had a question come in. So they were interested in what ORP would look like with potentially CBTI, not necessarily just the sleep restriction component, but the other components potentially related to hyperarousal. Do you have any thoughts on that?
No, I'm really looking for anyone who does CBTI to do, because I think that some of those people with hyperarousal will be the kind that I said, that just they don't need much sleep, but people tell them you have to sleep 7 or 8 hours. But some of them are not. Some of them also may be nappers, people who take a lot of naps, and they sort of take away all their sleep drive, most of my sleep drive in napping. And some of them may have real hyperarousal. There is a report from Vgontas and anyway from Penn State University that says that people with insomnia and a lot of awake time or short sleep duration don't respond to any of the 5 components of CBTI. Whereas ones that have normal sleep time do. So it is possible that some of these architecture patterns will discriminate between people who respond to CBTI and not, so that we can spare them the effort of having to go through it and put them on sleeping pills from the beginning.
Interesting. Okay, we have a question. How much do the multiple medications patient was on affect the ORP? Have you seen cases with ORP before and after CNS medications have been stopped?
We are just planning this study, and Amy will be the one taking the lead, because we are looking, I've been for forever trying to find literature on sedatives that are used for sleep and antidepressants and so on that would affect ORP9, because I think if we can find a sedative that lowers ORP9 or speeds up the progression to deep sleep, that will be the holy grail of sleep medicine. And so and the literature is really very scarce on the effect of these medications on the power spectrum of the EEG, which is what would help me determine whether it will affect ORP9 or not. But we are going to start getting people, normal people, and giving them normal doses of every conceivable drug used to sedate patients to see if any of them will improve ORP9. I tried on myself zopiclone and dramamine and I don't know what else I tried, a couple other common ones. All of them gave me worse sleep than my normal sleep. So I think something great may be available right now. We're just not realizing it, and so we're going to start digging into this.
So no information on benzodiazepines. That was a question.
Oh,
as
no,
well.
no, benzodiazepine is no good. Benzodiazepines are no good. They actually increase ORP. But zopiclone doesn't do much to sleep, really. It's just an arousal suppressant.
Okay. And also, do we know anything about distinguishing sleep fragmentation and ORP patterns between OSA and PLMS?
No, I have the data on PLMs, and I mean, as you know, most people with PLMs, the PLMs don't bother their sleep. It doesn't go, but you will get a little peak in the ORP with every PLM, whether it classifies as an arousal or not. But the base level of ORP determines whether or not you're going to have a PLM disorder or not. In other words, if your ORP9 and ORP are high, it's more likely that the PLM will be associated with an arousal and cause sleep disruption.
So not all PLMs are created equal, is what you're saying.
Not all OSA are created equal either. I think we're treating so many people that their sleep is not going to get better. And my feeling now, I mean, the impetus now in sleep medicine is to find out clusters of patients that will respond to CPAP and will be compliant with CPAP as opposed to others. And there's also the risk of hypertension and so on, whether there is a select group of OSA. The issue also is whether the cardiovascular complications are related to the sleep problem or are related to the hypoxia. And that is again unsettled, particularly after the SAVE trial in the New England Journal of Medicine a couple of years ago. So all these things now we can explore by looking at sleep architecture using this new method and see whether these different patterns can distinguish between people who will get cardiovascular problems or who will get sleep disorder or whatever.
And, typically a clinician would pull up a record and they would see the hypnogram across time, the distribution of stages across time. The way you were presenting it, it was a histogram, so percent in each decile. Are we missing out on any information by not having the histogram kind of across time throughout the night?
Oh, no, this is not to replace the histogram. In fact, the report the reports of this scoring, I mean, the last slide I showed, the bottom part of the last panel shows you the ORP against time. Okay, so that tells you, and it gives you an idea, just like I showed you, whether the ORP is rising during the night or staying flat. If it's staying flat and deep all night, it means you're not getting enough sleep. So this is an integral part of the report. The ORP micro architecture is only to replace the percent of times you spend in different sleep stages, rather than just having the 5 categories. We have these 10 categories, which gives you a much better look at the microstructure of sleep.
Okay. I'm also curious about how do we move people more towards normal, or how do we know even what, I mean, you showed us the histograms of what normal sleep looks like in these deciles. How do we then shift a person with sleep disorder to more of these normal, and how would we know that CPAP is helping in this individual? You know, like what would we would just see those shifts more towards a normal pattern, or how do you go about quantifying that?
Well, quantifying it is basically to get a mathematical function, get some mathematician to do a mathematical function and decide on 2 or 3 parameters that will tell you whether sleep is getting better or not. Or you can just look at it by seeing where the peak number of epochs occurs. The more to the left it is, the deeper the sleep, and the more to the peak is to the right, the worse the sleep. I don't know, I forgot the rest of your question. So you know how it is if you treat the patient. So the histogram will tell you whether there is the pyramid, if you see it in a patient who doesn't have OSA, tells you that there is something stopping this patient from getting into deep sleep, some organic thing. If it's not OSA, it may be PLMs, or it may be itching, like in the first case we discussed, or it may be some colic in the tummy or whatever. And so that is a very interesting kind of pattern that would prompt the physician to look for other reasons. If it's not OSA, to look for other reasons disrupting sleep and causing an increase in sleep pressure in the patient. The normal histogram is going to type 4 will tell you that, you know, treating CPAP with CPAP is not going to improve sleep. You know, whether you still want to give them CPAP for other reasons like severe hypoxia, or, you know, I don't know why else you would give them, or cardiovascular problems, then you can expect that their sleep is not going to improve. Whether whatever you want to treat them for then is going to improve, I don't know. That remains to be determined by clinical trials. But my view now is that only type 1 and 2 and 3 should be treated. These make up 60%, but you're not going to treat the insomnia. These people have to have something for insomnia in addition to the CPAP.
Mm-hmm.
So type 3 needs CPAP and something else for insomnia. 1 and 2 will do very well with CPAP. Type 4 their sleep will not improve. The next phase of the studies will be working again with colleagues, if anyone is interested, to see whether the improvement of sleep on CPAP in a CPAP titration, for example, will translate into compliance. Because right now, you know, when people are not compliant with CPAP, everybody's focused on the mask and the machine, and you know how to. And the CPAP companies spend a lot of time and money on trying different CPAP and tubes and BiPAP and C-Flex and whatever to see if the patient can tolerate it better. But most of the time it doesn't work. And nobody is thinking about the patient's not getting better sleep and is not feeling any better. You know, that is the main reason for poor compliance. And that's what I'm looking for, is people to work with to see if this prediction of improved sleep on CPAP will translate into improved compliance. In other words, how often is poor compliance related to lack of improvement in sleep quality? Patient doesn't feel any better.
Mm-hmm. What are your thoughts? And people, please submit your questions. There was a recent meta-analysis that came out that CPAP, is ineffective. And what are your thoughts on the compliance related to that? So in that study, it looked like average compliance was 3.3 hours. Is that enough to say that CPAP does not impact cardiovascular events or, along those lines? What do you think about that?
You're asking me?
Yes.
I have no idea.
Okay.
It's all waiting for studies to be done. I mean, as has been happening all along from the beginning, sleep guidelines are made by committee, majority opinion, and based on nothing. The only thing that there is some evidence that 4 hours gives you some benefit, but less than 4 hours doesn't. But whether 4 hours is different from 7 hours, I don't think there is any data on that. You saw the effect of CPAP now. I mean, it improves sleep only when you're wearing it, when you're eliminating, and only the part that is not awake. It doesn't change awake time. So in anybody, in any type of pattern. If you use it at 4 hours only, it's not going to be not as bad, not as good. What really remains to be determined, Amy, is how much of the complications of OSA that have been documented with great difficulty are related to sleep problems, not the OSA itself. Because there are many reports about non-OSA poor sleep being a risk factor for the same things that OSA was found to be a risk factor for. So it may all be related to poor sleep, not necessarily. So insomnia patients who don't have OSA have all kinds of problems, cardiovascular problems, cancer, diabetes, death even has been found to be higher in people with insomnia in the absence of OSA. So sleep may be the common denominator for the adverse events of sleep disorders. Mm-hmm.
Okay, well, thank you so much, everyone, for joining us today. We do have a part 3 coming here. It will be on June 8th, same time. So check out for that. Keep an eye out for that. And we will do a part 3 with a different case. So thank you so much for joining us, and we'll see you next time. Thanks, Magdy.
Thank you. Welcome.